Hello, my name is Katrina Scott, and I am the Academic Director at the Center for Research and Education on Violence Against Women and Children here at Western University. On behalf of the Learning Network and Knowledge Hub, welcome to our webinar, Supporting Black Survivors of Traumatic Brain Injury, Addressing Anti-Black Racism and Building Survivor-Led, Trauma-Informed, Cross-Sectoral Solutions to TBI. I want to acknowledge our work is located on the traditional lands of the Anishinaabeg, Haudenosaunee, Lenape, and Chewang-Tong nations. These lands are connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. We make this acknowledgement to counter the doctrine of discovery and recognize Indigenous lands and sovereignty. We also recognize that many Black people were violently displaced to Canada through settler colonialism and slavery. We will continue to work collaboratively with communities to challenge colonialism, anti-Black racism, and further forms of oppression that remain pervasive in Canada and that result in disproportionate impacts of gender-based violence on oppressed communities. Today, we are happy to be joined by Dr. Samira Omar and Dr. Gifty Asare. Dr. Samira Omar completed her doctoral studies in the Rehabilitation Sciences Institute at the University of Toronto and is a researcher in the Acquired Brain Injury Research Lab. Her doctoral research focuses on how institutional racism manifests in rehabilitation research and practice for Black survivors of TBI and considerations for investment in anti-racist care. Dr. Gifty Asare is a doctoral graduate in psychology and neuroscience at York University. Currently, she is a research lead for the Public Health Agency of Canada funded Women at the Centers, Cross-Sectoral Solutions, Strengthening Community Capacity to Address the Parallel Pandemic of IPV and TBI through a survivor-led support intervention project that aims to develop a rehabilitation program for IPV TBI survivors across Canada. This project is part of the Knowledge Hub. We will first begin with a presentation from Dr. Omar and follow with a presentation from Dr. Asare before moving to the Q&A session. Dr. Omar, I will pass it to you to get started.
Thank you so much. Hi, everyone. I'm Samira Omar, and today I'll be talking to you a little bit about how anti-Black racism shapes rehabilitation care pathways and what the implications are for Black survivors of traumatic brain injury. I also want to highlight that this is research from my dissertation. Before we get started, I want to draw your attention to these two icons, which you will notice on some of the slides throughout this segment of the presentation. So I mentioned earlier that some of this research that I'll be sharing is part of my PhD dissertation, and so some of that work is unpublished. And so in order to preserve that material, I ask that you please refrain from tweeting, circulating, or taking any screenshots of the slides. So the slides that have these icons. These are some of the learning objectives for today. And so I hope to take this opportunity to share a little bit about how systemic racism with respect to shapes care pathways for Black patients who are experiencing a traumatic brain injury. Learn a little bit more about how Black people with TBI come to access care pathways. and how concepts like sex and gender are often used in this literature to tell us something about how these groups of people are doing in terms of care outcomes and rehabilitation trajectories. And so I'm going to turn off my camera for the rest of the segment, and then I'll turn it on during the Q&A. I like to start my presentations using narratives and getting a little bit personable about how I got to where I'm at today in terms of doing this kind of research. And so my journey starts during undergrad, where I used to do a lot of volunteering at Baycrest, where I would do friendly visits with older adults who were diagnosed with Alzheimer's. In these weekly visits, together we participated in having conversations about important memories. I would listen to their stories, laugh with them, play card games, and ultimately support engagement in activities that were meaningful to them. It would always be the highlight of my week, and I would take this feedback back to the staff. I realized that I had a passion for supporting and enabling meaningful participation, but also in identifying what the barriers were. But then so much in my life changed when my own brother had a traumatic brain injury. And from these experiences, I got firsthand experiences of rehabilitation and the Ontario healthcare system. I then did my master's at Western University. And during this time, I reflected on my experiences with the healthcare system and supporting my own brother. And I reflected and wrote about these experiences in a blog piece for the Brain Injury Society of Toronto. At the time, I didn't have the language to articulate what it is that we were experiencing, but I knew that there was an important gap that needed to be addressed. So I came to do my PhD at the Rehabilitation Sciences Institute and get training at the Acquired Brain Injury Research Lab at the University of Toronto. For me, pursuing a PhD in rehab sciences has been a personal decision the moment that I realized that the only way that Black people with traumatic brain injury can have a chance at a life worth living is if people understood the inequities that were embedded within the healthcare and rehabilitation system. I never understood why people in healthcare and healthcare providers had to be convinced that his life mattered and he deserved care. These experiences for me solidified my commitment to brain injury research, but also in exploring the profound need to engage with what it takes for Black people with TBI to live meaningful lives where they can have every opportunity to participate in daily life. I looked to the academic literature to see what was written about these experiences and what happens when people who are visibly Black, along with other intersectional identities, enter into rehabilitation. And I could not find anything that helped me understand what I was experiencing. This is how I got to where I'm at today. And so over 30 years ago, a study by Jenkins examined how rehabilitation was delivered for Black people experiencing disability. And this study highlighted that these individuals were significantly dissatisfied with the rehab care that they received. Several decades later, rehabilitation continues to fall short of meeting the needs of Black people with chronic disabilities, such as those with a traumatic brain injury, and significant racial health disparities exist. These racial health disparities arise from systemic racism, particularly institutional racism, which is beyond individual actions and draws attention to practices, policies, and procedures that perpetuate disadvantage. And so we have a gap, a very significant gap in clinical care and research in traumatic brain injury, which is the lack of consideration for racialization, racism, and its related intersections. One of the first gaps that we addressed was the fact that no studies or reviews have exclusively focused on the clinical care journey for Black people with TBI, and then with a specific aim of addressing racism. And so to address this gap, we conducted a scoping review to better understand the extent, nature, and range of care pathways that consider Black people with traumatic brain injury so that we can map the scholarship that can tell us something about what the clinical care journey looks like for this population. And so the protocol for this scoping review is also published online and open access. And so in this protocol, you can also find key terms such as racism, race, racialization, their definitions, and some scholarship that you can refer to for your own reading. You can also refer to the published scoping review and the protocol for more details about the methodology. For the interest of time, I will only highlight key aspects of the methodology, but the papers are published online for more detail. And so as part of the scoping study, we followed a rigorous scoping review methodology, which consisted of 5 different steps, starting with the identification of the search strategy. And so in order to build our search strategy, so this image, this image is missing some text like boxes around, but that's okay. So in order to build this search strategy, we used a combination of search terms like traumatic brain injury, integrated care, and Black populations, which together yielded a total of 178 articles after removing duplicates. And 43 articles met the inclusion criteria for this review. So what did we find? Well, all of the 43 studies that were included in this review were based in the United States. Over 90% of the articles were quantitative in nature. Most studies included a range of mild to severe TBI, and adults made up the most common sample of participants that were included in these studies. In more than 70% of the studies, white participants accounted for greater than 70% of the sample. 3 studies were found where Black people made up over 80% of the sample. Just based on the title alone, 60% of the articles made direct reference to race and ethnicity. 81% of these article titles explicitly highlighted racial and ethnic disparities across TBI-related outcomes, such as community integration, medical disposition, and differential care and treatment. When we looked at what these articles focused on, the most common focus for the clinical care journey for Black people with traumatic brain injury was on racial and ethnic disparities in care, screening, access, treatment, and disposition. However, none of these studies identified the source of existing disparities. The top 3 most common care settings were in acute inpatient rehabilitation, emergency departments, and in community settings. When we look at how race, sex, and gender are positioned, 33% of the studies use the terms race and ethnicity interchangeably. 7 studies methodologically group Black people together under the category of minorities, and race is often used as an independent variable in 80% of the studies. We'll talk a little bit about why this is important in a moment. When we look at how intersections of race, sex, and gender are considered, we see that over 40% of the studies misuse the term gender to refer to dichotomous sex differences, such as male and female. Most studies did not report stratified data on the basis of gender or race. And a total of 7 studies reported data specifically for Black participants. 10 studies provided an analysis on the intersections of race and sex or gender, which gave us insight into how Black participants or Black patients with traumatic brain injury were doing. For instance, One study reported that Black females received less standard treatment procedures than white females. We also accounted for the different kinds of narratives that are produced about Black people in these different studies. Some of these narratives can be described as, where Black people are described as, include being unmarried, less educated, more prone to violent mechanisms of injury, and an at-risk population, and being unproductive. When authors make interpretations of these findings, some of the study authors use terms like bias, prejudice, socioeconomic deprivation, which are ultimately components of racism, but don't actually name the problem as being racism or related to anti-Black racism. And so racism remains disconnected, unaccounted for, and a problem without a name. As part of this scoping review, in our analysis, we also organized our findings narratively. And as part of this, we identified 4 different ways that anti-Black racism shapes care pathways for Black people with traumatic brain injury, including accessing clinical care pathways, how the mechanism of injury and other factors contribute to the care journey, how it shapes functional outcomes, as well as the long-term occupational impacts of anti-Black racism in the clinical care journey. For the interest of time, I will only focus on accessing clinical care pathways. From these studies, we see that anti-Black racism impacts how Black people with traumatic brain injury access care pathways, such as the fact that Black people were more likely than white patients to receive emergency department care from a resident than a staff physician, technician specialist, or another type of designated provider, even after controlling for other potential confounding variables. When they do gain access, Black patients are more likely to receive less intensive and high-level rehabilitation, regardless of insurance coverage, compared to white patients who were matched on other variables such as age, sex, insurance, mechanism of injury, and injury severity. Black patients were more likely to be discharged home compared to white patients. What are some key takeaways? Well, for one, this is the first systematic scoping review of the literature to not only apply a critical lens to map the literature, but also providing a special focus on the clinical care journey for Black people with traumatic brain injury, and specifically highlighting the different ways that anti-Black racism remains as an issue that is unnamed in the scholarship. I want to draw your attention to how race is applied in TBI research. When we often use race as an independent, moderating, control, or demographic variable, this can have particular implications because it may erase how racism shapes access, treatment, experiences, outcomes, and also long-term opportunities. Studying race as a variable that's independent of the structures that actually dictate what access to care and outcomes and opportunities look like reproduce the same kinds of harmful impacts that are detrimental to quality of life and well-being. But statistical data can be used to measure levels of racism, like perceived racism, racial discrimination, and unconscious bias, rather than reinforcing racial disparities. An important step is to raise the question of what race and ethnicity-based data serves, but as researchers and healthcare providers and other individuals working with Black people with traumatic brain injury, we also need to be critical about the kinds of knowledge that we are making sense of or reading along the way. It's also important that we use disaggregated data in order to make effective practice and policy changes, because aggregated data is dangerous. It loses data and ultimately masks how Black people are doing. How do we track outcomes? How do we track how anti-Black racism is shaping healthcare, rehabilitation experiences, and service use in a Canadian context without that data? But it's also important to, as researchers, when we're naming our studies and creating titles, to also be careful about how we do that, because language is political and it can shape perspectives and narratives. But then conducting the scoping review also introduced several gaps in this literature. And in addition to naming racism, we also don't have much scholarship, if any, about the firsthand experiences of Black survivors of traumatic brain injury. And so we can rely on this data to give us a picture about the clinical care journey, but we also don't know what these issues look like in a Canadian context. And often qualitative research that does include Black survivors of TBI as part of the sample often not only lack inclusion of Black people when they don't include them, but the ones that do significantly lack interpretation for how socio-historical, structural, and institutional factors perpetuate marginalization. These studies often tell a collective narrative about the experiences of people with traumatic brain injury, with no consideration for how racism and anti-Black racism can shape outcomes, opportunities, and experiences. And so to address this gap in a Canadian context, we conducted the Amplifying Black Voices in Traumatic Brain Injury Rehabilitation study to examine the narratives of Black survivors and their caregivers in a Canadian context. And so while I won't get into the details about the findings, I do encourage you all to look out for forthcoming publications and presentations where I will be going into more details about what we learned in these studies, the results, and future recommendations and ongoing work. And so as part of this larger qualitative study, we sought to recruit 3 categories of participants who self-identify as Black, are consenting adults, and communicate in the English language. We conducted this participant recruitment during the time of COVID. And one of the categories of participants were survivors of traumatic brain injury who received or currently were receiving rehab services such as occupational therapy, physiotherapy, speech-language pathology, or social work across Canada. And also self-identifying as someone with a TBI or diagnosed with one. And we used the Ohio State University Traumatic Brain Injury Identification Method tool in order to get more information about their history with traumatic brain injury. We also recruited family caregivers, such as unpaid family members or friends, providing support with activities of daily living for someone who is Black and experiencing or living with a traumatic brain injury. In Canada, we also broadened this search to also include community advocates, spiritual leaders, and others working for and with Black communities who hold this expertise. And the last category was rehabilitation providers, such as rehab nurses, occupational therapists, physical therapists, speech-language pathologists, social workers, personal support workers, and other rehab providers working across the care continuum in different care settings, such as inpatient, outpatient, and community. These individuals also had to have experience working with the population as well. And these are some key findings I also wanted to, again, just reiterate that I won't be going into any much details about the findings per se, but wanted to share that one of the things that we captured using the experiences of these participants was how institutional racism shows up in rehabilitation practice, and what their experiences tell us not only about how it impacts them, but how the system works, how practices shape outcomes, and how they navigated these experiences. We used critical race theory as a tool, actually throughout all the studies that we've conducted, including the scoping review that was shared earlier. And so I do encourage to please look out for forthcoming publications and upcoming presentations where we will be going into details about these findings and how racism shows up in rehab practice. Not only did we map the different ways that rehab institutional racism shows up in a practice context, but we also looked to the experiences of these participants to tell us what anti-racist rehab care can look like and what kinds of investments can rehabilitation make in order to promote Black futures. Some of you might not know, and some of you may know, but we are currently in the International Decade for People of African Descent to gain recognition, justice, and development. And so during this time, I'd like to also reflect and share a little bit about what the some ethical considerations that I took as a researcher doing this work and recruiting and talking to participants who are Black with lived experiences of traumatic brain injury. And in doing so, I want to draw your attention to the importance of building rapport, because it was incredibly important that rapport was built with my participants before starting the interviews, particularly at the time of obtaining consent and setting the first interview date. During this time, each of the participants were called and I introduced myself. I allowed them to share any concerns that they had or any questions they wanted to ask before they scheduled their interview and before they provided their consent. I wanted to make sure that the consent that they were providing was informed and that they knew of all the different details that can go into a research project and how their information was going to be used more specifically. Some of these participants, especially the survivors and family caregivers, were hesitant at first because they were wondering why someone at the university is asking questions about Black experiences in traumatic brain injury rehabilitation. Others were also curious about how I got into this research and why I was asking these questions. Ultimately, they wanted to know how their data was going to be used, what kinds of narratives were going to be told about them, and whether they were going to be identified in the process. Answering these questions was really important because, for one, for many of them, this was their first time getting exposure into research participation. But it was also important in order for them to make an informed decision about whether they wanted to participate or not. And so it was really important that I used my positionality and background in order to give participants a sense of comfort and trust in sharing their experiences and how their stories would be presented in writing and used in knowledge dissemination. But as a researcher, I quickly came to realize that not only did I have an insider perspective, but I also am an outsider doing the research and making these decisions. And so part of what my supervisors and committee really helped me with was thinking through these ethical considerations and what this meant in terms of the kinds of quotes that I would represent, how I would use these quotes, debriefing with me after interviews, as well as helping me decide on what kind of methodology to use specifically in terms of analyzing these findings and making sense of them. And so, in summary, the collection of studies that were completed as part of this narrative about addressing and confronting institutional racism and TBI rehabilitation and how it impacts the care pathways is not only timely and novel, but it also addresses a really important and critical knowledge and practice gap. And for the first time in rehab sciences, it provides an understanding of institutional racism and Black experiences of TBI rehab and brings these issues to the forefront so that we can continue to have conversations and think more critically about what kinds of actionable steps that we can take in order to create programs, services, and interventions that can help address some of the more pressing concerns about meaningful participation and living a quality life. And so we hope that by conducting these series of studies, future research can explore the profound need to engage with what it takes for Black people with TBI to live meaningful lives where they can have every opportunity to participate in daily life. I want to take a moment to just acknowledge the awards and funding that I received in order to do this work. As well as my doctoral committee, supervisors, my mentors, the many Black women who have supported me along the way that have cheered me on, my participants, and every person who has contributed in some way in either teaching me an important lesson or providing me with opportunities to learn and grow. I also wish to thank Diane, Katrina for inviting us to do this webinar today and to also learn more about what everyone in the audience has to say about our findings and perhaps next steps. And I'm also looking forward to listening to Dr. Gifty Asare and hearing and learning more about her work as well. Thank you so much, everyone.
Wonderful. Thank you so much, Dr. Samira Omar. That was a beautiful presentation. I can see in the chat that others echo that sentiment. It was very enlightening to hear about some of the findings regarding the experiences of Black people when it comes to TBI and institutionalized racism. So hi, everyone. Good afternoon. My name is Gifty Asare, and I'm going to be talking about survivor-led trauma-informed cross-sectoral solutions to IPV TBI. That is a mouthful, but essentially going to explore some solutions that we've been finding in the literature and also finding outside of the literature when it comes to aiding survivors that have experienced either intimate partner violence or traumatic brain injuries. And so my hope is that by the end of this presentation, we'll acquire some knowledge regarding select rehab professionals and peer support providers' roles in aiding survivors of IPV, as well will enhance cultural competence and awareness of diversity and inclusion when working with survivors affected by intimate partner violence and traumatic brain injuries. So to start off, I understand that maybe a lot of audience members here know what IPV TBI is, but this slide is really just to get a sense of the terms or the definitions that we used to explore this specific scoping review. And so we looked at intimate partner violence, which is violence occurring within an intimate relational sphere, as opposed to gender-based violence, which refers to violence against a gender, usually a gender that's considered a minority. And then for traumatic brain injury, traumatic being an acquired brain injury through physical force. So for example, a hit to the head or asphyxiation. And this is as opposed to a non-traumatic brain injury. So one from a medical event that includes a stroke, for example, or alcohol and drug use and abuse. So this is not to say that drug abuse, for example, its effect on the brain is not traumatic and cannot occur in IPV or GBV, because it does. But this scoping review restricted itself by using these specific terms. And this was done just to refine the review, but there is a lot of merit, and it's actually imperative to look at gender-based violence and acquired brain injuries as a whole. So why does this intersection between intimate partner violence and traumatic brain injuries matter? I believe that as a people, as a society, there is this long-standing history of not imparting the same value, importance, or stock on what it's not visible to the naked eye. So this actually bleeds into healthcare. And then, of course, it also bleeds into traumatic brain injuries. So it turns out that our brains are not indestructible, which is very unfortunate. But in reality, they're just blobs of fat, amongst other things, and they're easily deformed by the touch of a finger. That's how fragile our brain is. So much so that it's actually suspended in a sea of fluid inside of our skulls, inside of our heads. And then the brain is actually enveloped with a thin paper-like sheet to protect it. So looking at the brain at just 6 weeks, the embryo's brain is quite small, but the nervous system itself begins to develop to become, a full adult brain, which completes that development completes around the age of 25. So an adult brain is actually just as fragile. The casing of the brain, so the bones and that thin like sheet that envelops it, hardens a little bit, as does the brain, but not by much. And I could go on and on about facts about the brain, but it encompasses everything you know, remember, think of, experience. So it is crucial. It's also the only organ that we can't transplant at the moment, but science fiction novels are working on it, so don't worry. But I think that it's fascinating as a structure. But I say all of this as an organ, but I say all of this to highlight the importance of traumatic brain injuries, especially so in the context of IPV. So I've sustained a traumatic brain injury before, but in the context of sports. And the care is quite different. In IPV, survivors might be unable to seek care. They can be unaware that they have sustained a brain injury, and then providers can mistake the brain injury symptoms for emotional distress brought about by the abuse itself. So this is to say, in the IPV setting, because it occurs in a private sphere and sometimes in an intimate sphere, survivors largely have to advocate for themselves to get proper care. And sometimes medical attention is never sought. And if it is sought, it can be too late. And this is because maybe healthcare providers might be more focused on, let's say, the physical manifestations of IPV, or maybe the social setting might have more importance than the brain injury. There are also legal ramifications to take into consideration. And so I have this statement at the bottom that not only does IPV feed into TBI, but TBI feeds into IPV. And that's because it's important to highlight and to be aware that there is possible criminalization. TBI feeding into the criminalization, that is, of women during IPV cases. So usually survivors are asked to recollect information over and over again, numerous times, and they might not actually be able to do that or to do that well. So from a legal perspective, getting justice can also be hindered. So noting this importance, noting that TBI and IPV is highly prevalent, but goes unnoticed and is often overlooked, we wanted to see, well, what's the best outcome for successful community integration to target rehab interventions? And so we decided to look at select rehab professionals and thinking that these individuals might be uniquely placed to actually recognize a TBI and then aid in its rehabilitation. So we conducted a scoping review. This was a Public Health Agency of Canada funded Women at the Center study. And this was done looking at the literature and in a longer or a bigger project that aims to develop a rehab program for IPV TBI survivors across Canada. Okay, so our main question is, well, what is in the literature about the existing use and the opportunities for physiotherapists, occupational therapists, speech language pathologists, physiatrists, and the survivors that they provide for survivors of IPV. And to do this, we essentially looked at 10 databases, gray literature. We ended up including 31 peer-reviewed articles. We didn't have any restrictions on date, language, or location, but to be included in the review, the work had to involve an intervention provided by one of these 4 selected rehab professionals. And then that intervention needed to be about adult survivors of IPV. And that included domestic violence, dating violence, sex work, and sex trafficking. Again, we recognize that there are other rehab professionals that could be included in the scoping review, but we really wanted to address the gap in the literature. And so there was literature on, let's say, social workers and nurses and their roles in rehab interventions for IPV survivors, but we really wanted to look at this gap when it comes to these 4 select rehab professionals. And so we ended up extracting 44 articles. And just to give you a little bit of detail on what these 44 articles where they came from. So 38 were from the US, and I think Samira kind of echoed that in her findings as well. A lot of them were American, 3 from the UK, and then 1 each in Canada, Spain, and Brazil. And what we largely found for the scope of this review is that we can group the findings or these articles into 3 broad categories. So the articles discussed the interventions that were aiding in rehabilitation of survivors, or the knowledge and the beliefs around rehabilitating survivors, and also around what essentially these specific rehab professionals believed about IPV and about TBI. And then the opportunity to do more. And the rehab professionals were largely occupational therapists, and then followed by physiotherapists, speech language pathologists, then physiatrists. And so to note is that we went into this thinking that these rehab professionals are uniquely placed to aid in traumatic brain injuries, but we only found 6 out of the 44 articles assessed or reported traumatic brain injuries in their populations or in their methods. And so essentially, they used either a screening tool in these 6 works that they used a screening tool to assess for traumatic brain injury, or the survivors reported a history of brain injury. But none of these articles made recommendation based off of that assessment or based off of the medical history of survivors when it came to traumatic brain injuries. And then also looked at Black considerations in these 44 articles. And so this was after the fact, in the sense that I participated in the UN 67th Commission of the Status of Women, where we had a panel of experts discuss Black femicide. And I got to thinking, well, looking or having highlighted such astonishing rates of traumatic brain injury and of IPV in the Black community, then I would imagine this would be reflected in the works and in the literature. What we ended up finding was only 7 of the works included demographic information to begin with, and 6 included Black women ranging from these percentages. But again, no recommendations were made regarding women of color. But all in all, what we found in this scoping review was that there is a recognized need for rehab professionals to support IPV survivors because of how uniquely they're placed, and also because they actually come into contact with survivors more than once. Rehab professionals are underprepared to support IPV survivors. They do mention requiring more education and training to confront biases, to be able to identify and support survivors, which is good to know because people are at this webinar today to do just that. And then the interventions that we found for IPV survivors seems to be more positively received when they support life skills, activities of daily living, and then meaningful engagement. And so based off of this, we kind of identified promising practices for this field specifically. And what we highlighted was it's necessary to build intimate partner violence education into rehabilitation training. The rehab professionals studied reported being underprepared to deal with IPV, usually not necessarily having formal education during their studies on the subject. And when asked, the majority of rehab professionals, they wanted more information. They wanted more training about IPV specifically and how they could support survivors. Also, they wanted a recommendation network of local resources that rehab professionals can refer to if needed. Again, remembering that a lot of these works were published in America and the States and involved American population. We can think about the States and how the laws and the legislations vary quite a bit from one state to the next. This might and probably is reflected as well in Canadian regions and Canadian areas, even just thinking about rural areas, for example, in comparison to non-rural areas. We can understand how developing a network of local resources will definitely aid when it comes to supporting survivors. Lastly, a recommendation was to build flexibility into programming so specific survivors' needs can be met. Now, this recommendation actually comes from an interesting observation. So across the studies, when we were looking at the interventions, we essentially had about 9 works that were focused on interventions, and 13 different assessments or assessment tools were used across those 9 studies. And so at first, naturally, from an academic standpoint, that was more or less of a nightmare for comparison, right? Very difficult to compare 13 assessments across 9 studies to see which is most efficient and which isn't on different metrics. However, that also seems to be a strength when it comes to aiding survivors because it speaks to the flexibility of these assessment tools and the specific survivors that need rehabilitation or are in need of care. And so building that flexibility to accommodate for different situations and different survivors, different regions, is a strength and something that needs to be built upon, highlighted when it comes to rehabilitation for intimate partner violence survivors, as well as traumatic brain injury survivors. So some of the tools that actually came up more than once in this case were the model of human occupation tool. And so that provides a framework to guide program development. I'm just going to change the slide here. Oh, I seem to have lost control. Oh, there we go. And essentially, this framework is more holistic in nature. And because of that, it also is practical in assessing practical in assessing exactly how a survivor's needs can be met. Okay, so I'm hoping I'm still on the same slide as everyone. I think I see kind of jumped forward for me. All right, wonderful. The other tool as well that we highlighted was the Canadian Occupation Performance Measure. This is a good measure to assess progress outcomes, and this was also used more than once in the interventions. Professionals seem to kind of like it a lot because it provides, again, a more holistic view of a survivor and how they're doing over time. However, it is worth noting that these tools don't have specific considerations for TBI or for diversity. So while it can come through implicitly, it is not explicit. So that's definitely something to make note of and something that we hope can be improved upon. So the other area for this project that we wanted to look at is not only rehab professionals, but let's look at peer support and how this can help in TBI, IPV, and then also looking at the role of social work as well. So the objectives here are, well, what are the effects of peer support on IPV? What are the effects of it on TBI? And what's known in the literature about the role of social work in TBI IPV or IPV TBI. So here again, just like the previous scoping review, the words or the terms that we used were the same. And the findings here for peer support was that we ended up with about a literature scan of 10 review articles. And this again was looking at how peer support can help rehabilitate survivors. When looking at only peer support on IPV, only 4 reviews were identified. And these reviews were not specific to intimate partner violence. And so they looked at violence as a whole, injury, crime, calamities, and suicide. And it was suggested that peer support can definitely provide positive outcomes as well as negative ones in some cases. And in a specific review, it stated that it hadn't been found to be more or less effective than free-flowing speech. Now, there is a disclaimer here because, again, this work is not specific to intimate partner violence. And then the other thing to note when I kind of delved deeper into these articles is that I noted that when it comes to peer support and the methodology. So for these for this specific review, it was a 90-minute peer support group session once a week for 8 weeks that was facilitated by a trained nurse. And in the free-flowing one, it was essentially one session once a week for 8 weeks, but it wasn't facilitated by a nurse. And so again, it was still peer support, but there was no facilitation by what we would consider a rehab professional or a professional. And that kind of suggests that it is not necessarily a structured peer support that is facilitated by a professional that will yield benefits or positive outcomes, but just the fact of having a peer or someone that has gone through the same experience, lived experience that you have, can be beneficial. We looked at the effects of peer support on traumatic brain injuries. In this case, we had 6 reviews. And in context of TBI, what's a little bit more clear in that it was usually positive outcomes, but not only for those that have experienced a traumatic brain injury, but also for the caregivers. And so they mention how peer support is actually beneficial to the caregivers of individuals having gone through a TBI. So in general, we concluded that peer support can definitely have positive outcomes. But the negative outcome here that is important to note was that there is a possibility of re-victimization. In this sense, it's essentially this possibility of actually going through trauma again by the retelling of the experience. And this was noted only when looking at peer support on IPV. However, again, as I mentioned, this wasn't actually an IPV setting, but looking at individuals that had suffered from injury, crime, and also the experience of veterans. And it has been noted in the literature that veterans actually do experience re-traumatization much more frequently than other groups when it comes to peer support. Next, we looked at social work and IPV and TBI. This was 13 works. And in this case, essentially, social work plays a vital role in supporting survivors of TBI and IPV. It provides safety planning, referrals to community agencies, and counseling services. Social workers did mention that sometimes there can be a lack of knowledge within the social work field in identifying and then subsequently in aiding and supporting survivors of TBI and IPV. And so the recommendation here was not only to build brain injury and brain injury in IPV education into the rehab program, but to also provide information or knowledge and education around brain injury symptomology, specifically the differences between acute and lingering traumatic brain injury symptoms. And I thought that that was actually quite fascinating that social workers would highlight this because it speaks to the long-lasting and continuous nature and relationship that social workers have with their clients. Because of this, they've essentially noticed that there is a difference between symptoms that are acute and immediate and those that are lingering, and they highlight the importance of addressing those differently and looking at them more in depth as well. And so we can kind of summarize all of the recommendations that I've talked about here on the slide. I think it's important to incorporate the findings of literature, but also of the narratives that are shared through peer support and through professionals' experiences with these populations or survivors at large. There's mention of incorporating standardized assessment to screen for TBI in survivors of IPV, which is naturally important to aid in the symptomology. For example, when I was mentioning acute and lingering symptoms of traumatic brain injury. But on the flip side, it's also important to notice that that can have some legal considerations and ramifications when it comes to women survivors kind of advocating for themselves in their situations. And then also highlighting here at the end, the last point, the importance of WESEC. And so this speaks to the importance of survivors being the experts on their lived experience. And so it's something that I've now been I want to say blessed and lucky to made privy to. I've definitely largely been in the academic world, but through this project, I've gotten to do research in a different way where I get to have the experts, those that have actually lived their situation and the experience, kind of inform research and how it's going to move forward, and then taking those narratives and actually incorporating them into the outcomes, into the conclusions, into the knowledge dissemination as well. And so I definitely think that it is important to allow survivors to inform how best they can be served, how best they can be cared for, and naturally how best they can be rehabilitated. And so kind of to end, I've got 2 slides here to kind of wrap up some considerations when it comes to Black survivors and how we can practically aid in the rehabilitation and care of these individuals. And so I know Samira spoke to some of the ethical and institutionalized and anti-oppressive and racism against Black people. There is something called the strong Black woman narrative. And so this is essentially a narrative that not only comes outside of the community, but within the community, where it's kind of embedded in we don't talk about this sort of thing. We just bear it and we push through. And it creates this image that, the strong Black woman, she's resilient, she can take on anything. And a way to dispel this narrative is to create a safer space for Black women so that they can be more vulnerable. And one way to do that actually kind of is in the different, so the next column where there are disparities in healthcare. So this strong Black women narrative, for example, can also be fueled by the fact that in healthcare, you might not necessarily see the signs of intimate partner violence as easier on someone of a darker skin tone, someone with a darker skin tone than someone with a lighter skin tone, right? And so that kind of feeds into, well, then you must be okay. You must be well. You don't have bruises. You don't have signs of physical violence. And as I mentioned, this is kind of like traumatic brain injuries in a way where we don't see something, so we don't treat it. Not only do we not treat it, but we don't address it, we don't care for it. It goes unnoticed. It feeds and almost helps in the erasure of women in this way. And so looking at disparities in healthcare and how this can be dispelled and how this can be addressed is also, there's also this emphasis of including Black population in research works. Samira spoke about this at length, but I think it's important to also note that the relationship between Black population and research is not one without strife. And so it can be challenging, it can be difficult, but it's worth noting that that difficulty or that challenge doesn't stem from anywhere, right? It comes from somewhere. And that feeds into my next column, which is education and language. So it is important to take history into account. It's important to look at community practices amongst the population. And although we're speaking here about Black women and Black survivors of IPV TBI, I think this goes to say for example, Indigenous communities as well. And so we're accomplices in this realm when we're advocating for history and community practices to matter to professionals, to rehab professionals, and those that are in a place to give aid, support, and care. And a way to do that is to dismantle oppressive language. Again, something that Samira spoke about a little bit, but in my next slide here, I've got two terms that have been introduced to me recently that I love. And I think that these were either coined or at least started by Nneka McGregor, as well as Dr. Tope Adefarakan, when it comes to language that can be used in a more positive way, in the sense of aiding in dismantling in dismantling racism when it comes to Black women, Indigenous women, other women of that are considered minority in the healthcare system. And so one of them is misogyny versus amorgyny. So to love, like, trust, have faith, and believe in women and girls manifested in various ways. And then misogynoir versus amorginoir, where amorginoir would be to love, like, trust, have faith, believe in Black women and Black girls, Black gender diverse people specifically. And so I'm hoping that these are some practical ways that we can all engage in to help aid, support, rehabilitate survivors of IPV TBI, specifically Black survivors of IPV TBI, having noted that there are some challenges, and recognizing, acknowledging these challenges will definitely help us better address them. And so thank you so much for your attention. And I definitely look forward to the questions and the discussion that will ensue.
Thank you so much, both of you, for your presentations and for your remarks, and for all the people who have shared their love for this in the chat as well. I'm glad that we have a bit of time for some questions. So myself and Sabri will be kind of passing back and forth. I'm going to start with a question that's to either one of you, but it's it's really a question about, I think it's maybe a question about terminology um, and limitations. So one of our audience members asked about why you're limiting to traumatic brain injury as opposed to acquired brain injury. And maybe some of your thoughts on the ongoing problem of seeing the larger picture of all brain injuries.
Yes, this is a very good question, and it is a discussion that was had many times. As mentioned, it's true that it's limiting to just look at traumatic brain injuries, but we found that there has been confusion in the literature itself when it comes to using these terms. It was also like an oversight on our part, but it actually ended up aiding us because we did find so many works when it came to traumatic brain injuries and acquired brain injuries, and we wanted some specificity to kind of narrow it down. And so just for example, acquired brain injury in some cases, for example, would be referred to like acquired through a stroke, right? So as long as it wasn't congenital in nature, it was included. Whereas traumatic sometimes would be definitely much more narrow in looking at those that were just attained through physical force. But as mentioned, there is acquired brain injury that intersects with IPV-GBV, and that is worth looking at as well. So I hope that helps, but all of that to say that I agree that acquired brain injury should be looked at when it comes to this matter.
Thank you.
Thank you. The next question will be for Dr. Samira Omar. Do you know if the findings of your scoping review are similar across other minority ethnic groups?
That's a really good question. So I would say that some of the so this literature about racial and ethnic disparities, which a large part of the scoping review draws on that literature. So when we look at the literature about the clinical care pathway for Black people with TBI, a lot of this literature is based on racial and ethnic disparities literature. And so as a part of the samples, there are other ethnic minorities that make up what is considered as part of racial and ethnic disparities. And so when I was going through these different articles, yes, like I would say yes and no in terms of similarities. I think the experiences or the outcomes that are particular to like Black people with TBI are more like pronounced and nuanced. A lot of these studies that highlight these disparities often highlight the outcomes related to the Black population. And I would probably guess to say that the outcomes are a bit more severe for this group as opposed to other ethnic minorities, but I think a lot of these outcomes are also similar at the same time too, in terms of like not getting access to rehab or experiencing like differential kind of outcomes and that sort of thing. So I would say like there are similarities, but there are also like profound nuances that I think we would know more if we knew about their firsthand experiences as opposed to relying on the quantitative numbers to tell us that there are disparities on the basis of race and ethnicity.
Thank you.
Yeah, Samira, I'm going to have you kind of continue a little bit from that thought, because one of the things you talked a little bit about was, well, of course, you've just now emphasized the importance of getting people's voices, and you talked a bit in your presentation, but can you talk a little bit more about any advice that you might have on how to approach communities to talk about their experience and anti-racism, anti-racist rehabilitation, like you have, and when you want to build that rapport with communities and with lived experience experts?
That's a really important question. So I guess I can answer that like from my own experiences. I guess what worked for me was I had an interest in these intersections because of my own lived experiences. So that allowed me to ask the kinds of questions that I did and get to know people. And so before I ever like expressed interest in wanting to do this research, I had to get to know people so that people knew more about what my interests were, what I had hoped to do in terms of like my dissertation. And it was getting to know those the people that I did along the way, the different kinds of like community TBI organizations that allowed me to even find the participants that I did during the time of COVID. And so those individuals connect when they got to know me and the time came to do this study. It was a matter of like reconnecting back with them, expressing to them that this is what I had want to do, and having them connect me with people with this kind of lived experiences. And a lot of it was just connecting on a human level and doing a lot of like back and forth sharing before we even got to the part where we were like formally doing the interviews and recording the sessions. A lot of sharing, like, you know, why I wanted to do this work, just like more like trying to like relate to them on a human level, and getting to know them and then expressing to them like what does it consist of to be a part of a research study. How am I going to use their experiences? Because it was really important that they also knew that like not only am I a person who has these kinds of experiences, but I also am a researcher. So I would have to make decisions about how I use this data. And so for them, it was also important to know, to trust me that that this experience wouldn't be exploitive, and I won't be taking their experiences and regurgitating in a way that did more harm than good. And so building those relationships and then also keeping in mind like the histories that Dr. Gifty spoke about in terms of like oppressive practices and research, like accounting for that as well too, and being mindful of that like in the decisions that we made over the course of doing this study.
Maintenant, on va avoir une question pour Dr. Gifty.
Here's a question for Dr. Gifty.
Translate my French. So,
The question for Dr. Gifty: how our traumas from the past affect the Black women's capacity to recognize the traumas and that are a consequence of their relationships?
I don't know if I need to wait for English translation.
So yes, I will translate again. So
you said, how do past traumas of Black women inform?
for how do they use?
How do the traumas of the past affect Black women's ability to recognize and deal with the new forms of trauma that are consequences of their relationship?
Right. That is a very good question. Also a mouthful, but very good question. So one is the past traumas of Black women, something that I didn't specifically study. I just look at kind of past trauma in general, not specific to Black women. And so how that will inform, you know, women's experience after, Black women's experience afterwards, I can't specifically speak to, but I'm definitely interested in finding out. But I know that I did speak about re-traumatization and sometimes re-victimization, and I can speak to that, and hopefully that might kind of help shed some light on what could happen for Black women specifically. So when looking at peer support, and some of this also can might be stemming from, you know, personal experience or lived experience, was that there is kind of, you know, peer support is powerful in that you are sharing your experience and you're retelling your narrative. And sometimes that narrative can be very emotional. It can also be, kind of, full of triggers, I would say, is what we kind of call them today, where, there's some pretty important or deep themes that come from the narrative that you share. And through that, people can relive the experience that they themselves have gone through while sharing it, but they can also relive, even when you're talking about, let's say, how you went through the healthcare system, and you're telling someone, like, how they treated you when you went there, how you went through this system, so forth and so on. Even reading about past relationships of Black people. So when I read about the Tuskegee syphilis experiment for the first time, while not necessarily going through that trauma again, the retelling of that narrative and those experiences themselves definitely kind of feed into re-traumatization, if you will, especially if you have your own lived experience and you empathize with that specific situation. And so when it comes to the realm of peer support, and then it comes to having rehabilitating and care, I think that those are some of the lines that we need to navigate very carefully. I say that to say that in peer support, for example, you might have some that might not be as, maybe as careful or compassionate when it comes to understanding someone else's narrative, hearing someone else's narrative and comparing it to their own. And so I think that that's why maybe there is sometimes a greater risk of re-traumatization, and then the past trauma feeding into that. But I think maybe Dr. Omar also might have an answer to that, working specifically with Black populations.
Thank you, Gifty. Samira, do you want to add anything?
Yeah, it got me really thinking about like, even when we were conducting like the interviews, at one point, we built into the protocol was like, we wanted to like make the transcripts available to the participant so that they can let us know if if there's anything to change, to also remind them of what we had chatted about. But I very quickly found out after the first participant that perhaps this is not the best way to go about it, because of the whole aspect around re-traumatizing the individual and having to see like your words on paper, and how that, like, it's one thing to tell your story, but then to have to relive it again by like having to reread like pages and pages of like transcripts about what you shared was probably not the best way to go about it. So we quickly made an amendment and changed that very earlier on in the process. But yeah, that was a little some of like my experiences of I guess how trauma comes up in, I guess, talking about these experiences, but also like our responsibilities as like providers or researchers, and the decisions that we have to make to account for like how that affects the well-being of the person who has this lived experience.
Thank you. And if I may, just to like add on, actually, you bring a good point. So recently, there was a webinar about Indigenous practices, or including Indigenous considerations in research. And that is something that they mentioned, because of this rereading of your story kind of maybe being re-traumatizing. They explore different ways of sharing researcher findings. And one of those was through art, which I thought was interesting, where I'm kind of using another method instead of the written word, or maybe the spoken word or video, using kind of a visual aid to share a lived experience was sometimes better. So something practical to take away from that, maybe that can help others.
Thank you.
Well, and I think what we're going to do is a close with a question to both of you around thinking about what might be done in terms of changes to healthcare or healthcare policy or practice. And, Samira, you talked about the impact of racism being systemic. And so it's coming in all different parts. And some of our audience members reflected that, even in the standard patient care, there might be ways that hospitals or practitioners kind of cover up these concerns. And others talked about the challenge potentially of making people more mindful. So I guess my question to both of you is, if you were to choose your most important kind of changes that need to be made, what would you recommend that we be working towards?
I can get started. I think this is something that we're also like thinking through. Like, it was one thing to like do these projects, and then now thinking about how do we do knowledge dissemination. And I think that's exactly it, like disseminating that knowledge. How can we like getting this information to the individuals who not only make decisions at a more systemic level, but at the level of like the individual, the ones who are providing that care? How can we help them understand the consequences of their actions? Because racism falls on a spectrum of not just the policies and practices, but also the kinds of decisions that we can make as healthcare providers in terms of like what treatment options we provide, what kind of what do we take into account to get to know the person, to then offer them a treatment plan that considers their specific needs. And so getting this information to the people that are providing the care, I think would go a long way, because many of us, when we go into healthcare, for one, like we don't go into with the intentions of wanting to produce harm, but then that can easily happen when we're just following standard procedures and protocols, because often these these assessment tools or these protocols that we follow were not really created to account for like the needs of like Black or Indigenous populations. And so how do we come in with the mindfulness of like an awareness of these issues, but also what are the creative ways that we can work around that? And so I guess knowledge dissemination would be like a really important aspect, like getting that information to the people that need to hear it at different levels, so that we can start working on these changes like more like immediately. Because of course we do have the work ahead of like creating programs and services, but all that takes time. So what can we do to get that information out now so that people can start making changes that can impact quality of life, like in real time?
Yeah, no, that's a wonderful point, and I echo that 100%. I think to add on to that really is, if we're going to disseminate that knowledge, then producing that knowledge would be essentially like the other end of it. And so as I went through these like reviews, finding out that in the production of these works, Black folks are not necessarily taken into consideration or added when it comes to like the demographics, or when it comes to actually even the therapists or the professionals that are providing the aid. And so producing the knowledge in that sense, where we are actually including diverse folk, and also including what they consider to be a source of aid and support, is one area that I found lacking, and is also kind of the next step of this project. And so we looked at rehab professionals, but now let's kind of look at other practices that people consider to be care and support. And so, for example, that could be mindfulness. It can be having a community leader or spiritual guide or spiritual leader, for example, taking into consideration all of the avenues that are specific to Black folks and then specific to minority groups, I think is very important moving forward, to help the knowledge that is being disseminated, that knowledge to be well-informed and well-rounded.
Thank you. I thank you for everybody. I just want to say thank you to start to Sabri for joining me with the questions. As we started, I forgot to introduce Sabri. He is the implementation coordinator and the Francophone liaison for the Knowledge Hub. Thank you for joining us for these questions. I also would like to say thank you to our presenters, Dr. Omar and Dr. Asare. Thank you as well to the ASL interpreters, Joanne and Christopher, and to the French language interpreters, Carolyn and Audrey. Don't forget to complete the evaluation form to receive a certificate of participation. A link is going to automatically open in your browser after the webinar has ended. Thank you, everybody, and we look forward to seeing you at the next webinar.
Thank you. Merci.